I have the honor of introducing Dr. Dondanville, so I'm going to read a little bit about her quickly. Dr. Dondanville is an associate professor and a licensed clinical psychologist within the Department of Psychiatry and Behavioral Sciences at the University of Texas Health Science Center at San Antonio. She is the director of the Strong Star Training Initiative, which is grant-funded implementation and dissemination program for evidence-based psychological treatments. Since 2017, the training initiative has trained more than 2,000 mental health providers across 44 states, disseminating evidence-based practices to thousands of individuals with PTSD, suicide, insomnia, and nightmares. She's consulted with numerous community organizations and clinicians regarding the successful implementation of evidence-based treatments. And I know today she'll talk about implementation, but also de-implementation. And we are also honored at UT Health that she is one of our experts on our behavioral health ECHO program. So I hope you all will check that out as well. And I'll turn it over to Dr. Dondanville.
Awesome. Well, thank you. What an amazing conference. And thanks to the conference organizers and presenters. This is my first time here, and I just really feel grateful with all the content and support. So I also welcome everyone. This, I would say, as it relates to the other things that are going on, it might be a little bit, the other things might be a little more interesting than implementation, but this is kind of the place in which we get stuck in making changes. Excited to talk more about it. Uh-oh. So I have no financial relationships to disclose. We've got our learning objectives today. And a little bit more of an intro and a disclaimer. I am a clinical psychologist. I am not somebody who does clinical treatment in the same area that you all practice. So I'm an expert in the treatment of PTSD and trauma-related disorders, which leads me to be kind of adjacent to substance use area. I do a lot of training of clinicians working with organizations. I'm also a researcher, but the things I like to research are around like getting things that work into settings where our clients and populations want to go, which is not always my office. And so that's kind of the work that I do. And I'm not an expert in the things that we're going to be talking about. One of the things as we think about implementation science, it's helpful to use some non-sciencey language. And so you hear me talk a lot about the thing. So the intervention, the practice, the innovation is the thing we want to change. We've got effectiveness research that looks at whether that thing works. And implementation research looks at how to best help people and places do that thing. That's why we're here. And the strategies are the stuff we do to try to help people and places do this thing. One strategy is this conference, right? To get knowledge. But the main implementation outcomes when we're thinking about measuring success is how much and how well do people do the thing? So one of the things that is really frustrating, and we're working on accelerating, but it takes a long time to get from research into practice. Too long. People have ideas, then they have to seek funding for those ideas to study that idea, and that takes a while. Then they finally get the funding to do their research study, and then they start to do that study, right? And we have all sorts of things that go on while we're trying to do that study, but it's going to take about 6 years. Then we get done with that study, and we got to publish those results. And the first time that I was a part of a clinical trial and those results got published in JAMA and everybody was celebrating, I was a research therapist on that trial, and I remember reading this 5 pages and going, this is it? It's like 5 years of my life. I don't know how this is going to change practice because it doesn't really tell anyone what to do, these means and numbers and standard deviations. And so dissemination is different than just publishing those results, right? And our goal is widespread practice change, that people start doing this thing, that the thing is available for consumers, that people have choices. So if we start with something simple like washing our hands, turns out we know how to wash our hands. We've got steps, right? We've got implementation strategies like sing the happy birthday song twice. That'll give you the 20 seconds. Dry your hands. And you know what? It's not that simple. We healthcare providers do not wash our hands effectively. We actually have a global hand washing day. There is so many resources put forth to help us to wash our hands. And that is fundamentally very simple, right? And so I just want to point this out in that, like, the work that we're doing to change is hard. And that getting this idea from research to practice, and even after we know the evidence, getting to that widespread practice change is not simple. In reality, it's decades. We've got so many ideas, not as much funding. We got research studies, then we publish those results. And in reality, years later, right? And more years later, right? We go to conferences, we talk about this stuff, we start initiatives, we get funding, we set policies, but it's hard for that widespread practice change. There's a lot of barriers. So one of the things that's really important is thinking about how do we evaluate the evidence? And the good news is that no individual has to take on the exclusive responsibility to do that. We don't have time for that. Many of us don't even have access to these articles. And what are the key takeaways? So we have other mechanisms. We have clinical practice guidelines. We've got professional association standards. We have groups of people who are working to help us to know what are those evidence-based practices. So in this audience, we have a lot of disciplines. Any psychologists, social workers, counselors, right? Physicians, nursing, peers, right? What else am I missing in this audience? Pharmacy, researchers, right? So we are all working in an interdisciplinary world, and so we have different messages coming to us from different places. And so when we look at our clinical practice guidelines, some of the things that are really important and have been incorporated so that we can have more confidence in these guidelines are related to stakeholder engagement. Right? Transparency in the process and in who are the people who are helping to evaluate and create these. There also is a process for managing conflicts of interest, right? So me, Katy, psychologist, many of us, we don't have any financial conflicts of interest, but as you work into more of drug devices, different things, is that we are all working across different boundaries, but it's not, we need to manage those conflicts of interest. And then establishing evidence foundations and ratings for, like, the strength of those recommendations. And the final piece of our having clinical practice guidelines we can trust is external reviewers, right? So we don't need and we don't have to have just one person making decisions. And so when I look at kind of what's out there regarding this area, we've got a number of different places that we can go to help understand some of those guidelines. This is not all of them, but these are examples of ones that I've pulled up, and they may be things that help guide the work that you do. And each year, right, we've got more and more groups continuing to push them out. Now, here's the thing. When we deliver these clinical practice guidelines, there's not just like, ta-da, right? Now we're all doing that. That's what happens. It's not how it works. In reality is these get published, right? And we're waiting, and we're hoping, and we're waiting some more. Then we're presenting at conferences, and we're talking about it, and we're sending emails. How many emails do we get about this stuff? Associations. And it's not exactly how we sort of envisioned what it was going to look like in real life, right? So we go from the guideline to like reality, right? Things get a little contorted. So this is how we get things into settings, right? And it can look like this. It's hard. It's not that simple. And so for all of you that work in settings and programs where you've made a practice change, you've stood up a program, it is a huge accomplishment. And you should feel really proud about the work that you do. Now, we know that there are lots of different factors that are contributing to helping get the thing into our settings, and that it is not so simple. It's not just Katy psychologists making a personal decision to do this new practice. Because I work in a system, and in that system, we've got an outer setting, right? Even if I was Katy psychologist in private practice, I have to think about things like policies, laws, licensure, financing, who's paying for the thing, right? How do I get paid? There are also values and beliefs, right? These things, right? What people think about things is something we can change, but it is also oftentimes a barrier for change. There are partnerships. So then there's the internal setting, right? The inner setting. So this week with Be Well, we're thinking about like, how do we get our electronic medical record to get us the information that we need for the reports that we need for the contract, right? And turns out electronic medical records, you know, they need a few more of us on their teams to make them more user-friendly, right? I mean, why did you put that measure over in that corner? No one's gonna find that. What's this workflow? Like so we're dealing with systems that are just not built for us. So there's structural, there's also priorities. We have conflicting priorities of the things that we do. It's not just one thing, we're doing 100 things, right? There's also culture. Some of our organizations, we've built really strong cultures, and then we have personalities and turnover. There's mission alignment. Sometimes that thing may conflict with a different thing in mission. And the availability of resources. We don't have, resources are people, resources are also time, right? We don't have enough of either sometimes to be able to do things the way we want to do. And then we go down to the individual, right? So we've got lots of different roles. We've got many different roles, but we also have like champions. We have innovation leaders, right? These are more informal roles, and you've had that in your own system. And at each of these this is what's called the consolidated framework. And what I like about it is it helps to just look at the complexity of these things. And we have to think about like, what is the area that we need to act on in order to make this change. So one of the things about me is that probably since I was, I don't know, a toddler, I would just always say, yeah, but. And my theme song in my family was, you can't always get what you want. So it turns out I've made an entire career out of doing that, right? Like, and not stopping, like, well, we'll just find a different door. It's not a hard no. But part of implementation is being really persistent and creative around, like, what are the factors we can move? What do we need to move around in order to have the shared mission, which I think even kind of all of our maybe pain points in our system, we do have a shared mission in that we want to provide quality care. And other things interfere with that, right? What that looks like. So I want to just kind of give people these are just really great resources for people doing this work. I think CFR and the REAIM, like these are practical things that you can use in the settings that you use, but they help to really think through like what changes, right? What levers can we pull? So we've talked a lot, that was all about like how do we get new things into systems? Well, we also have things that don't work, that are harmful, and getting them out of practice is really hard because getting them in is hard. Now getting them out is even harder. So, and we've got some things in this area that we're all working collectively to get out of practice. So when we start with, let's think about this program, right? You're laughing. We have known for decades that not only is this ineffective, it's actually counterproductive. But guess what? Still offered. I even pulled up their 990. They got a ton of COVID money. Ton of money. I think it was like 20 million that year. The amount of money that the DARE program has is insane, given what we know about the evidence, right? And so de-implementation is the deliberate and systematic process of discontinuing or ceasing a particular medical practice, intervention, or treatment that's been found to be either ineffective, harmful, or no longer in alignment with our guidelines. So the American College of Preventive Medicine has an opioid work group and a great paper out there with really specifics around de-implementation strategies. These are things that we are working collectively very hard to reduce and remove from practice. And so I think as you look at this list, I would guess that these might be things that you all are working in your systems to do and really thinking through, like, these are things we know are ineffective. We know that these things are harmful. And so we're working collectively to make those changes. So how do we make these changes? So if I back up, so Eric, in the implementation world, they have like all these acronyms and frameworks, and someone even wrote a paper like, let's stop doing that. Like we've got like 100 of them now. Like let's just agree like we've got enough. But Eric is just like strategies, right? Things to do. And they inventory those strategies. So how do you know what strategies to use? And one of the things about implementation, and when you start to kind of look in this area, is like they're wrapping kind of research and science around things you do all the time. And so as we kind of go through this stuff, you might think, oh, I do that, right? That's an implementation strategy. You're doing that to either increase something or decrease something, right? So the key thing is thinking about what is the thing you're trying to change, and what is the roadblocks, the barriers, the things that are making it hard to make this change, and what are the things that help make this change? What do we think is going to help make this change? And who are the stakeholders around this change, right? And who are the people we need to talk to in order to move this little chess piece in getting this thing either out or in? And so if we think about our strategies and we think about the things that we do, some are top-down, right? And some are bottom-up, but most effectively are things that are using both, right? I don't like being told. I don't know about you. I don't like to be told. So top-down is just not always it's not going to be sufficient to make that change. Bottom-up is about creating that culture among those stakeholders and helping to inform, and also to discover more barriers, right, and facilitators, right? Why is making this change not working? So I'm going to talk a little bit about a couple different studies in this area and the things that they're doing to make change. And I think some of it aligns with some of the stuff that you all might be doing. So one of the things that we use as it relates to increasing a thing in the medical world has to do with training, right? We just need to train people, and then they'll start to do that thing. That's one piece, right? Training. But some of what we're all struggling with, and in order for you all to come to this conference, and maybe some of your colleagues didn't get to come to this conference, is the resource of time. We do not have a lot of time. We don't have enough time. And so we're always thinking about, like, what's the least amount of time or training, right, to get the result. And so this study really looked at 4 different methods. So the first one is in-person learning collaborative. A learning collaborative is bringing together a team of stakeholders. So not just, they're talking about expanding the use of medication, not just prescribers. Thinking about clinic leaders, all the different interactions, bringing them together and working together to make this change. Learning collaboratives include didactics, training, but they also really include a lot around, like, thinking through your system, identifying your barriers and facilitators, and thinking through what are the steps I would need to make. They are time-consuming. They usually have multiple learning sessions. So you've got maybe 4 people going, 5 people going multiple times in person. That's expensive, right? Especially here in Texas, everybody getting to one place is really expensive. But they are intensive, and the learning collaboratives have been used across many different things, getting things into practice. Webinars. We get emails for webinars all the time. Webinars are a great opportunity to get knowledge out. We're not going to take away skills in a webinar, but we're going to learn a lot about knowledge, right? ECHO, which Adrian talked about. ECHO is such a really interesting mechanism. I think it's a really cool thing. I just started to be a part of a hub, but it's a really innovative strategy where there's some didactics, there's some case consultation, there's discussion, and it's really a learning community. That's really great. And if you haven't already participated in an ECHO, you should. But you're typically 1 hour a month, so that's much less time. And then the 4th condition was a twice-yearly clinical skills training. So just focusing on increasing those clinical skills. So what this study was doing is thinking about, like, what they wanted to see is new patients being prescribed buprenorphine, that word. We all know that word. So I want to go through just a couple slides of kind of showing what they found. So what you see here is time on the bottom. On the y-axis, we have like new patients receiving. And most importantly, what you see is the black line is who showed up, and the white line is they didn't go. Because that's the other thing we have to pay attention to, is just because we have a thing doesn't mean we can all go to the thing. And so in the learning collaborative condition, they saw an increase, right? We even see an increase in those that didn't show up. And I would guess that that has to do with the fact that their colleagues in the system is changing, right? So we'll remember this. These images aren't great. That's just the way they were in the journal. But you see, right, 5.71, right? That's kind of where we want to get. Echo. Huh, look at that. Much less time, right? But we see, again, if you show up, it's going to be better, right? But we also see kind of improvements not showing up related to the system change, right? We're changing culture over time, too. But not enough as showing up. Didactic webinars, again, right? We're seeing improvements. And not showing up, that's improving too, right? We're having some culture change. And then the clinical skills training, not as robust as the other ones. Because it's really not about knowledge, right? It's not that I don't have the knowledge to do this. There are other things impacting that. And so this study, the learning collaboratives led to the most significant change, but they were also really impacted by attendance. And so we know that we need a broad array of strategies. It's not, just like we're talking about with our clients, for us, it's not a one-size-fits-all either. And so one of the things I'd really recommend you all bring back is those echoes. That is a really efficient way to get information and skills. And if you have a chance to be involved in a learning collaborative, those can be really, really beneficial. They're not always available. So this is a different study, and this is really related to thinking about those knowledge and attitudes, right? So the keynote this morning, I think one thing that Dr. King stood up and said, wow, this really congealed for me, and it changed my attitude about things, right? So we know that when we do training, we can change knowledge and attitudes. But unfortunately, right, this study didn't look at behavior change. And so that's one of the most important indicators. Like, are we doing the thing more? We're pretty good at increasing knowledge. Just because I know something doesn't mean I do it, right? So if you were in this room earlier, you might have been a part of the motivational interviewing and the different, and I've known for years that mindfulness is great, and I would love to have a practice, and I don't. So what is going on there, right? Behavior change is really important. So when we think about strategies for implementing low-value care, things that are not adding, they're not doing, some of the most common categories are training and education of stakeholders. So that's also one of the things we're minimizing is that it's not just the people in the room that are the stakeholders, right? Our clients, our patients, the folks that are referring, our people who help us with our electronic medical record when we need something to change in order to get this thing in there. We have a lot of people, and we need to help them understand why we're making this change, right? And what do they think about this change? How do they think that would affect their work, right? Another thing that's really important is using evaluative and iterative strategies, meaning like I have to constantly change. I need to see if what I'm doing is working, and then if it isn't, or it isn't working the way I want it to, I have to tweak it. We also need to think about how do we support clinicians in making it easy. So working with BeWell, we've implemented some measurement-based care, and we have to think about, like, I don't want to do math. I don't want to add up that PHQ-9 or that DAS. Like, how do we use electronics to do that for us, to make it easier? And for clients. I don't know about you, whenever I'm a patient and they're like, oh, did you fill out the whatever? Like, well, where is it? Oh, you have to like click here and then click here and then click there. It's like, you lost me. Like, I'm a terrible patient. So I think some of the things we have to think about when we want to remove something from practice or put something into practice is we need to think about every single person along that system and think about how do we explain this in our educational materials in the language that makes sense for them, right? We have some didactics. We're pretty good at that. That's one thing that we're pretty good at. But we also need to not only create educational materials, but get them to the places, right? And we need to evaluate, we need to audit and provide feedback and tweak and develop and organize a way of monitoring. We're often just focused on getting things done. Actually taking time to look at the data is something that's a luxury that we don't always have. And so thinking about how do we do that in a team is really, really important. I think the other thing that is really important is thinking about advisory boards, work groups, like bringing together people and identifying champions. There are people who are like, yay, I'm so excited about that. Anyone who reacts this way, that's a champion. We want to bring them in on the team. We want to help them talk about the thing. Why are they excited? Tell me more. I know why I'm excited, but what makes you excited, right? And then thinking about the different financials, right? Like, so what does this mean? We may have some opportunities to think about what do these things mean? The other thing that's really important is to think about your physical environment, right? Changing that infrastructure. So what is it going to take in a day in the life to either stop doing that thing or to do it more, right? And we need to support clinicians, things like reminders, peer review, kind of creating a culture where we're kind of championing that when we're doing more of the thing we want and less of the thing we don't want, but not punishing or shaming when we're not there in that process. And so if we think about the work that we do with motivational interviewing with many of our clients, it's the same at the system level, right? In that there are reasons why people are doing what they're doing, and that some of those things are working, and some of those things are not working, right? So how do we help them move closer to where we want them to go with this thing? Things have to be adapted and tailored, and we have to really think through, like, who are our consumers, and are we communicating with them in the way that they're receiving information? So as you look at kind of how do we drive towards success, right? We've got these national initiatives, right, that top down, but we have to work with our local leadership. We have to look at our resources. We gotta also bring on our clinicians and champions and work together to develop this new care process, right? I'm gonna stop doing this thing, I'm gonna start doing this thing, right? And so it is an ongoing process of refinement and thinking about the work that we do as we're always refining it and creating that culture within your teams. So these tables are kind of text dense, but I think my hope is as you get access to these things, these can be documents that you can think about in your own setting And so what you see in this table, I've got a few slides of it, is the first column is what happened, right? How do we think about that in the CFIR? Like, where does that fit? And then what did we do, right? What implementation strategy? So those clinical practice guidelines, that's way outer setting, right? And that they often mandate change, which if that was sufficient, we wouldn't be standing here, right? But it's way outer setting. But when we think about our local initiatives, we have to think about like our champions, right? Engaging that champion, activating them, finding our champions. When we think about our inner setting, is thinking about our team that we work with, right? Capacity, shared information, strengthening our communication networks. And, you know, I think that we use this term a lot, but I think it's so important. It's like this idea of a local needs assessment is about what is working, why, what isn't working, right? We've got this thing that we'd like to either stop doing or put in, and thinking about what would that mean? What would that mean if we do that? And the more that we can bring in stakeholders and really kind of strengthen that team approach. So there's a lot of different ways in which we can do that. So you can see here we've got more examples, like we've got staffing, right? Or maybe thinking about reassigning roles, like what are our available resources? Revising our professional roles or creating new clinic teams. What does that look like? I'm constantly talking with systems about a specialist model versus generalist. Does every clinician need to do everything? If it is a specialist model, then we have to think about how do clients get to that specialist? Because if they just get the first person, like it's oftentimes in behavioral health care, the person who does the intake is now the clinician, and then you're like stuck like taffy. And you may not be the right person for that. And so is it even possible for me to know all things and do all things well? Or is there like a referral highway to be able to pass? And then the other thing that happens is we open those referral highways, and what do people do? They pass all the problem clients. And then systems say, ooh, that didn't work. So we're gonna shut that down. We're gonna go back to that generalist. But there are ways for us to think through, like how do we set this up in a way that increases our shared goal, which is the highest quality effective care. Okay. Oops, this is our little quiz question.
Maybe. Thank you. You can answer this question in Whova. Since y'all are here, I'm sure we can just answer aloud as well. But if you're online, you can answer in Whova. And we are in the hybrid Zoom session, so we're about to move to Q&A. So I'll direct you to the microphone, or you can flag me down, and I'll jog over, give you a mic at your seat. Thanks.
All right. So all of these things, right? Understanding what's kind of making it hard, what's greasing the wheels, our facilitators, talking with the different stakeholders, and top down and bottom up. We can't exclusively do it bottom up if we don't have leadership support, but we also don't succeed with only top down. So I want to talk a little bit about a tool that you can use to help do these types of things. And a really simple way to approach changes in your organization, whether it's adding a thing or removing a thing, is through a plan, do, study, act cycle. It's called a PDSA tool. And there are a lot of great resources. So these websites have toolkits, they've got videos, they explain each step. But the most important thing I like about PDSA cycles is they just make common sense. And so what is it, right? So the first step is plan, right? We want to understand the barriers and challenges. We have a thing we want to do. We need to create a team who's going to be a part of that. and a process of how we're gonna move forward. And these teams, we need to determine what is the data that we're gonna look at in order to determine if we are successful. So we got plan, do, right? So let's do that. So we're gonna initiate those processes by the team. And then we gotta look at the data. Using that data to determine, like, is this successful or not successful? And what is learned during the cycle is to improve. We don't expect to just do this one time and then voila, right? It's perfect. But it's an iterative process. We continue to look at what's happening. We even reevaluate the who, the how, the what. So here's a worksheet. I think this is from the WHO website, the WHO website. But it's really simple, right? So first starting with, like, who's the leader that's going to take responsibility, right? Who should be on that team? And to whom should the team report the challenges or successes? Those may seem like simple questions, but often we're making changes and we don't actually think about these things. And so writing that down and identifying that is really a key step to that iterative process. How, right? So what is the schedule and process that should be used for reporting problems or changes? What are the new aspects of this process? What's the desired outcome? If this works, what do we want to see changed? And what are the team's best guesses about what might work, right? Common sense is helpful, right? We know in our system, like, what are the things that, and who are the people that get things done? And where are the roadblocks, right? So what do we think is the best guess about what is the strategy to move forward, right? We wouldn't, like, pull up an Eric Rolodex to learn that, you know, that this scheduler, man, she just gets things done. Or in our site, we've got this epic, like, team member, I don't know, she just digs into a problem and she figures it out. If she left, we'd have a problem. We gotta find a new Tiffany. And what, right? So thinking about, like, how are we gonna look at this data and determine whether it's been worked, right? What would be the way we'd identify, we'd quantify whether this has happened? Sometimes we do one thing and we get some other outcome that we didn't realize. So in the work that I have done in clinics is that we spend a lot of time thinking about what kind of measures we're going to implement, and there was a lot of worry about these measures, and it's going to take so much time, and clients aren't going to like it. And then we're like, okay, so these are the ones we wanted. We're going to cut those in half. The moment we implement them, and we implemented some tools and things to make clinicians' lives easier, they said, can I have more? I would never have expected that outcome, right? That was a good outcome. We don't want too much more, but the fact that they liked it, I wouldn't have said would have been what we predicted right away. And so thinking about do we need to go through this again is really important. Now, sometimes we think to ourselves, like, that's a lot of time. I don't have time for that. But at the same time, we do end up wasting a lot of time trying things, but never really being able to evaluate whether it is. In my work, we do a lot of webinars. I don't know if those webinars are really that helpful. I don't really think they change a lot of practice. They take a lot of work. But it's been hard to evaluate that. What is the value add? Is the value add the fact that it's reaching an audience, or is it that from those webinars, people sign up to do something more intensive, right? Neither of those things are necessarily being evaluated, right? Or is there a third thing, right? Why are all these people coming, right? And so thinking about kind of working through and just looking at the things that we do in this way across increasing things and taking things out of practice is really important. It actually saves time instead of waste time. But thinking about, like, bringing together a team that is focusing on this and carving out a little bit of time a month to be looking at it. All right, so I've got like a lot of references with the hope that maybe some of these resources, as we think about, I'll back up to this guy, can be really helpful as you think about making changes in your organization and making it easier to make those changes. Okay? It's a very exciting topic. So, thank you.
All right, y'all, we're gonna move into Q&A. I'll start with one from online.
Yep.
For those newly implementing SUD screenings into their daily practice, what is the best or easiest way to implement so we can best serve these individuals?
Yeah, so I think a couple things. One is we have to figure out method, right? Do you have a way to do that electronically, right? Is that something that can be built in, and is the way it's built in easy for your population? So electronic ends up being a way that you can look at data really quickly, but our electronic medical records are not built very easily. And so we just had a conversation this week in that if you build it in where it comes a certain way, it's hidden from the client versus like we've all checked in for an appointment post-COVID and we have to answer those COVID questions. How do we get the questions there, right? Like, so it's sitting with the Epic person and be like, no, I want it there. How did you get it there, right? But at the same time, sometimes tech ends up making it way harder. So paper and pencil and thinking about, is that a part of the check-in process? How do you make it so it's easy? Do I just make sure somebody's checking to, we've got a folder of screeners, and so when I get into my office, like I have them, who's making sure I don't run out of those screeners? What do I do with the paper afterwards? So just thinking about what are the things you can tweak to make your life easier, and maybe we have someone, if we're doing paper and pencil, whose job is every Friday to go check to make sure everybody's folders have enough, and if they don't, they add, a big stack more, right? Because if Katy clinician has to also monitor that on top of that, when I run out, I'm probably gonna stop doing it, right? So how do you make it easier? Yeah.
Okay, so my question is, I hear a lot for implementation about like, find the champions, you know, but I feel like sometimes the same people are always the champions, and then they're the champions for everything, and they don't have the time to do anything else.
Yeah.
So is there a way to develop people into becoming champions?
Yeah, so one thing to think about is, like, what is it about, like, I'm working with these agencies in New York. It's called like SNUG, and it's a community violence reduction program. And like the first person who is gonna complete learning this thing, they're like, I'm not surprised, it's her, right? So what is it about her, right? What is it about this person, and how do we get her to talk to other people and make them excited about it? And who's like that second early adopter? And so it's less about, like when I think about that, I want her to be talking about like, what did she see different in her client, right? I want her to think about like, how is that impacting her practice, right? And then I want to start to see like what the spark is. So her storytelling, her outcomes, doesn't necessarily mean I'm like sucking her in to be a champion, but I'm seeing like where's the spark, right? So looking for opportunities to celebrate together and to get other people to talk about it. And then thinking about like, who are some of those early adopters? Who are the influential people in the system? So we can have both influential positive people and we can have naysayer influential people. So like, thinking about what do we need to do to that naysayer, right, to make sure that they don't suck all the oxygen out of the room. How do we, because they're not, I often think about our naysayers, the yeah butters, right, which is me too, is like, there's some reason they're saying yeah but. And some of them can be converted to the highest champions because maybe they don't quite understand, or maybe they're going to point something out we're not thinking about, right? Great, we're going to do paper. Well, we don't have a photocopier, right? Who's going to hand it out? A lot of the champions end up being more support staff, right? And like, this is great, clients are liking it, right? The fact that in the meeting that we was talking about with the measures, one thing we didn't realize is this has been happening for a long time and clients are getting to their appointments on time. So the thing we were most worried about turns out is not happening. But we hadn't talked about that, right? So bringing that up because maybe people aren't realizing it, right, if it's working well. I hope that's helpful. It's hard work, right? Yeah, other questions?
Another question from online while you guys think. What practices in MOUD are most in need of de-implementation?
Yeah, so let's go back. So I think one thing for you to really pull up, and this is readily available online, the full article, but the American College of Preventative Medicine and Opioid Work Group have an entire section on this. And so I think probably other people in the room might kind of share, right, these examples. We really need to be working on these. Other things from the audience, things we need to stop doing? Yeah, Adrian? Yeah.
One that I think is really critical, and our keynote speaker touched on it yesterday, but not referring people for mood services or not offering mood services when they aren't able to provide behavioral health services in conjunction.
Yeah.
Because we know the standard of care is still to provide those even if they can't be provided with the behavioral health services because of the potential impact on reducing mortality. So for a long time, the messaging was always to provide mood in conjunction with behavioral health services. And of course, that's not a bad thing. And most of us do that. And we expect good outcomes from that. And we see that, we have a big body of literature, obviously, for the effectiveness of behavioral health services. But even if we can only do mood, we should still do mood. And so for some, I think that becomes a barrier.
Yeah. All right. Yes.
Hello,
Hi.
my name is Lee Holly. I'm a therapist in private practice in
Awesome.
Austin. So my question is, as far as implementation or de-implementation strategies go with topics that are particularly contentious or emotions might be high, people might be passionate or agitated about a topic, what's been your experience in dealing with that level of like contentiousness?
Yeah, I mean, I think we all are humans and we have a lot of feelings, right? So I think some of it is that when there's a lot of feelings is understanding why, right? What is going on? What are the feelings around, right? If I stop doing this, what is my feared outcome? If I start doing this, what is my feared outcome? Because if I can't get to the outcome, right, but I just have a lot of feelings, then we're just unproductive. So I think like some of that is that, really partnering and understanding it more and thinking about like, is their feared outcome realistic, right? Do they have a point in that feared outcome, right? Is there some sort of other step that we need to bridge in order to move towards that? But I think that when there's big feelings, oftentimes it just shuts things down. And then we don't have a dialogue. But we have to build a dialogue, a culture of respect for, and not make assumptions. So oftentimes the assumption of what the feeling is about may or may not be the thing. So when I think about the work that I do around training clinicians in evidence-based treatments for PTSD, is that I know that even among clinicians that don't like these therapies, that we share a goal of helping reduce suffering. And that they're thinking about their goal a little differently. So learning more about what that bridge is, and I think the session before, what I liked about this, and sometimes I don't hear this in trainings, is giving people permission to have their own style. This thought that we're gonna be robots. We're not robots. We're each gonna do things differently, but we need to sort of follow that guideline in order to get to that optimal outcome. So making space for that. And that's time consuming, which sometimes is the problem, right? I'm not patient enough. Because we just want to bulldoze forward with our thing. Just do it. I hope that's helpful.
It is. Thank you.
Yeah.
Hey, this is interesting. Van King, Buell, Texas. So at the risk of some controversy,
Yeah.
I've heard a lot of different things about that seeking safety for trauma stuff, and that's still very popular, especially in substance use treatment locations. Is that anything that you would like to comment on?
Yeah, so seeking safety, for those, I'm guessing you know, it's like a group-based intervention that's around skills, and there is some evidence that it reduces PTSD symptoms. One of the biggest challenges around the comorbidity with PTSD and treatments are we don't have really good groups that are open groups that are evidence-based. So cognitive processing therapy is a group treatment that is an evidence-based treatment for PTSD, but it's a closed group. And that sucks in a lot of settings, because how do you carve that out? And so some of the things that I hear in a bad way is that people are running it as an open group. And then a client shows up and it's session 6 of the content, so they have none of the foundational stuff. And then they think that's cognitive processing therapy didn't work for me. So I see a lot more harm in doing things in not the way that they're meant for our patients, right? Because now they think that they can't be helped. And so I think like seeking safety is skills-based. I think if our ultimate goal is to reduce PTSD symptoms, it's not going to be sufficient enough. But it may be an option on a menu, and it works in many settings. But I also have a dream that we really think about kind of bridging our work together in co-locating effective treatment for PTSD. It's often done individually, but not all clients want to do that. So having a menu of options is really important. And so my take on it is it's one item on a menu that can be really helpful, and it's better than nothing. And it's definitely better than contorting something that then we don't know will work. Yeah. Yeah.
Hi, my name is Deborah Wootring, and I am with the UT Health Heroes program. I'm a part-time employee there, and I'm working on a master's degree in social work, and I'm halfway through my program. I'm on the fence about whether or not I want to be a clinical social worker or a macro social worker, and I was wondering what the macro social workers say about change in systems, and whether or not we've got some literature or some expertise on how they would weigh in any differently or add to this conversation.
So not as a clinical psychologist, I say this, and I respect all of our clinical psychologists in the room, but social workers are taking over the world. Like, and our social work colleagues, I think, are way more positioned as it relates to understanding systems and thinking about systems. Our social work colleagues are leading these systems, and they are the implementers of these. And us psychologists tend to kind of get pulled into clinical trials and kind of eggheady stuff. But I think like the field of social work is along with nursing, nursing is kind of the first implementation field, is one of the most robust fields. And I think one thing you don't have to worry about is like, you don't have to make a final decision. You're gonna have lots of chapters of the work that you do. I never thought I would do this work. Like, I just wanted to be a VA clinician and there was a federal hiring freeze. And there were no jobs. And so I was like, I don't know, I guess I could do like therapy in a clinical trial. And then 13 years later, I'm a researcher too. But like, I think just be open. But if your brain works this way, just keep letting it work this way. We need more implementers, people who are helping improve systems. Yeah. Yeah.
Just give my observation. I think some of the most effective social worker administrators and system leaders are clinical.
Yeah.
I think they've got a lot of that foundational experience that really helps you to understand.
Yeah. Having a clinical foundation is really helpful. All right, thank you, everybody.